everybody. Thank you so much for being here in Buenos Aires for the PCI Global Summit. I would like to thank Professor Sohbi, my dear friend, and Dr. Sariq, the co-director of the meeting, and also our panelists today. We have with us Dr. Ahmed Al-Sayed and Dr. Yared Sadek. So without any further delay, I would like to introduce my team, Dr. Fava, our nurses, Dr. Ganoun for echocardiography, Victor is a technician for Medtronic, and Dr. Gomez here for the anesthesia. So Dr. Juan Gaspar is going to share with us the slide of the case that I will share with you. We will share the screen. This is a 80-year-old male. He's suffering from hypertension, dyslipidemia, and diabetes. He also suffered from a chronic atrial fibrillation. We can discuss later on about the management of this patient. And he has a PPMI, permanent pacemaker implantation in 1917. He also suffered from colonic cancer. He was operated on some years ago. Now he is doing well. His renal function is a little bit deteriorated. He is under this clinical treatment. He presented with dyspnea in a low functional class. And during the transthoracic echo, they showed to us that he suffered from severe aortic stenosis with a gradient, the peak gradient of 70, a mean gradient of 43 with an aortic area of 0.78 square centimeters. His left ventricular ejection fraction is 48 with a discrete pulmonary hypertension with a 59. The STS score is 6.1, sorry. Next. And so the heart team decided to send the patient for evaluation for TAVI. This is the coronary angiography. You can see it's normal. Next. The right coronary artery, and then 2 injections in the left. We have a kind of breach in the middle segment of the LAD, but nothing important. Next. So once again, the LAD is quite without lesions, only this breach in the middle segment. Next. This is one spider view. Any significant lesion? Next. And here we have the CT scan evaluation for TAVI. It's a good candidate for femoral access, no significant calcification. Iliac artery is big enough, both sides. We have chosen the right femoral artery for this approach. As you can see on the right of the panel, there is a significant angulation of the aorta. The angulation is 53. So it's a challenging case from this point of view. Next. And the other issue is here. This is a tricuspid aortic stenosis with significant calcification, but the measurements of the annulus is quite borderline. We have here some measurements close to 28. I don't see the numbers so well, but the perimeter is 93. In some measurements and 94 in another and 91. So it's exactly in the borderline of the 34 evolute valve. But considering that this is a patient not candidate for surgery with this tricuspid valve with significant calcification, anyway, we decided to proceed for TAVI. You see on the right of the panel a significant calcification. The coronary height is close to 12 and 15 for each of them. And then another additional problem. We have analyzed the case for the using of a cusp overlap technique that we using normally here in our lab. With this kind of technique, we have decreased the permanent pacemaker implantation from 18 to 6.6. But in this case, it's also difficult for the following reason. The cusp overlap technique is going to be in a right anterior oblique 22, but with a caudal angulation of 50. It's an extreme caudal angulation. Next. In an evaluation, next. Sorry, we have escaped one slide, sorry. So we have decided to go for a near cusp overlap view for this case, because 50 is almost impossible to reach in the caudal angulation. Let's go for the first injection. As you can see, this is in a very caudal angulation. It's in a 24 right anterior oblique on 40 caudal. And as you can see, we cannot reach a complete overlapping of the right and left cusp. Next. We try in a near cusp overlap here, which was suggested by the CTA evaluation, which is right anterior 6 with the caudal 39. And you see that it's almost a coplanar view. So this is significant rotation of the heart, the aorta. Next. So this is probably the best or the nearest right and left cusp overlap view. Please stop the video there. Paralo ahí. You see there the right coronary cusp and a little bit below the left coronary cusp, which is significantly calcified there. But this is in a 35 caudal. So we will use this projection because it's the only possibility to work. Because if not, I have the machine here. Next. Next. La próxima. Okay, so we cross the valve. We try always to cross with the pigtail and with the J warrior. Remember that this is a leaflet calcification, not commissural fusion. So in most of the cases you can do it. And in this, with this technique, you prevent any kind of puncture of any ventricle wall.
So when you have a tricuspid valve and open leaflet, you cross with pigtail and normal wire?
Yes, absolutely yes. And you can cross in probably 80% of the cases. It's very difficult if you have a valve in valve. In these cases, we don't even try. You can see here we have a little bit bleeding here in the left groin because we have a 7 French here with the AO18 wire doing a crossover to protect the access here, where we have a 16 French, the pigtail, and we have the pigtail for the test. Considering the case and the angulated aorta, in this case, we have decided to prepare a Landerquist wire. I shape the tip, and then I introduce a second curve, as you can see here, because the aorta is significantly angulated. So if you agree, we can introduce the wire. And then we proceed with the predilatation. We have a 20 millimeter balloon for predilatation. And Victor has already prepared the valve there. Are you okay?
Yes, yes. Choosing the Landerquist in this particular case is a very good choice, I think, because of the horizontal anatomy. Yes.
Perfect. So I think it's a challenging case for different situations. Especially in a case where it's not so easy to reach the cusp overlap view. Second, because the angulation of the aorta, and third, because it's in the borderline annulus. So probably the only one situation which is totally solved is that we have a permanent pacemaker. Acá dejando la guía empujando.
Do you use Safari wire frequently, or?
In most of the cases, we use Confida, or some cases Safari. But as you know, Dr. Gemal Gada, who taught us about the cusp overlap view, is a very fun user of the Landerquist, because he said that with this wire, you can stabilize the valve a little bit better while deployment. Víctor, yo después. Ok. Stop. Bueno.
¿Bajo?
Dejando la guía. Acá. Sí. Está conectado. Okay. Patient is okay.
Do you do pre-dilatation in every case, or what's the percentage of pre-dilatation in your
In
center?
most of the cases, we are using pre-dilatation. We were fan of not using. We have some publication about that. But now we are convinced that we can use it in most of the cases.
In your cases.
We only predilate in some selected cases when we have rheumatic aortic stenosis or some bicuspid cases, or we are facing a case where we have heavily calcified valve with non-homogeneous distribution of the calcium. Otherwise, we go for a direct valve implantation without predilatation. What about your team?
This is good.
Yeah, the same.
Let me show you
the same
something.
here.
This is the port of the core of the Evolut in a 3-hour position. So in this position, in almost 80% of the cases, we can get a good commissural alignment for further coronary access. Probably this is not the case again, because it's a very old patient with quite normal coronary arteries. So dame la amplas.
Okay.
So I will reposition the pigtail. And as you can see there, cada position. Once again, one shot there. Okay, I think it's acceptable. So we are going to be in a very strange position. Ponelo más lejos. Probably here. Vamos a hacer a 120. Cuando yo te diga, let me hold the wire. This is totally uncomfortable. So we start the deployment and the middle part of the pigtail loop. Haceme mini test, Víctor. Un poquito, no más, dale. Empieza ahí. We will start here very slowly. Very slowly. The valve is moving deep.
Yeah, rapid beating will be helpful in this case.
Yeah.
Moving a lot.
Now, 120.
Voy.
We don't have a good
120.
pacing now. Okay, the valve is moving. No, let me recapture. The pacing is not the best pacing we have. But now it's okay. Let's go. Mantenerlo a 120.
Bueno.
Dale. So we are going here. It's a little bit tension now. Test, Victor. Perfect. Keep doing. Slowly, slowly, very slowly. Keep doing. Keep doing, keep doing. Keep doing, keep doing. Okay. Okay. Stop pacing. Bájalo.
Voy bajando.
So now we have to check the contact in the left cusp, but not the depth there. Let me do an ancho there. It's extremely difficult to find a good projection. Anda más frente. We don't have a good alignment of the valve. Let's go caudal. Caudal. It's almost impossible to get a good. This is a really tough case. Let me review the previous image. So here we have something important. The valve is in a perfect contact with the left cusp. And we have to decide with this, which is the depth here on the non-coronary cusp. That's something we are not sure about it. Let me check here, which was the initial projection. Vamos a hacer una inyección here. Vale. To be honest, it's not It's not the best, but I like it. Comments?
Yeah, I like the position too. I like its position.
Okay, okay. Juan, Dr. Gaspar, you are an expert.
I believe that you are in the right position. It's a 34, highly calcified. That's okay. Probably 4 or 5. That's okay.
Okay,
No
let's go a
pacing.
little más caudal. A ver. Let me do. No,
Could we
sácale,
get,
sácale. It's extremely difficult to. Yeah.
Could we get an injection?
No, no. All right. Yeah. We will do it. Let me. I am searching a position here.
Yeah. In cusp overlap view, injection will be helpful too.
Okay. I think it's a good position. Dale, sacale un poco de caudal. Let me check it with less caudal. It's almost impossible to get the parallax out. No, más caudal.
¿Más caudal?
Yeah, more caudal. You know, we have tried in almost every position. Más, todo.
Much better here, much better.
Yeah. Okay, let's inject there. Okay. I think it's okay. I'm not gonna get anything better there. So let's go with the pacemaker 120 with very slow movements, pacing.
Do you like to withdraw the pigtail, or do you like to keep it till
No,
the end?
I will keep there. Dale. Test. Position is okay. Dale. I am pushing a little bit now. And now it's okay. It's okay.
¿Bajo?
Sí. So, to be honest, I like it. I think it was a very challenging case. What do you think?
Yes, it was very challenging in multiple terms, but you had a very excellent result, actually.
To be honest, I don't remember a case where we couldn't find neither the cusp overlap view and neither to get the parallax out, which is the case. Yeah. But this is for our friend, Dr. Sophie. He asked me to do a challenging case, not a boring case. So we only see a very small posterior paravalvular leak. Gradients are almost the usual gradient. You can see on the screen, probably you are not seeing the hemodynamics, but this is, the gradient here is 10, less, 5. So I think it's not significant. We will do an angio, and I think we are almost done here. Let's go. I think it's a very nice outcome. Yeah, do you like it?
Yeah,
so,
yeah, I like it. I like it.
Okay, perfect. So consider this a case that we have to then shorten. For my side, we are done. I will give you final comments or questions. If not, we are done. Dr. Ahmed, Dr. Yasser.
Thank you, Dr. Mendiz. Go, Ahmed, go.
Thanks a lot for the very nice case, and you did a very challenging case in actually in very short time. So that means you have very good experience with this valve platform. Now we are going to close the femoral access with two proglides, as I just understood.